and podcasting. My topic is Olapariclus bevacizzimus as first-line maintenance in ovaries cancer. In definition, bevacizzimus is a drug that the slows to the score or slows the growth of the advanced stage epidemic ovarian cancer. This drug seems to work best when given a low dose therapy working well in the of the shrinking tumors. Bevacizumab is in class of medical called angiogenesis inhibitors for cancer to grow and spread the node to the make node wall basis success can neuritis desmer.
With first-line treatment, undergoing first-line treatment in Europe. And so the question is whether olaparib replaces bevacizumab, whether it should be given with bevacizumab. Unfortunately, the trial did not have a fourth arm of olaparib alone, so it was not possible to disentangle the effects of bevacizumab from those of olaparib. So I think that will raise a lot of discussion as to whether or not olaparib and bevacizumab have any additive effect in these patients, and they're both expensive drugs, or whether we can get by with just having olaparib, reserving bevacizumab for those patients who are not suitable for olaparib, perhaps because they don't have homologous recombination deficiency.
Application in nursing. This medicine is used as the infusion into a red berry to treat with the very other outcomes side effects such as Higgs wall precure children being lost with wall the cell counts headed most ulcer loss of the appetite in the diet.
I mean, these are practice changing, and so really the immediate implications are hopefully that we get the drug available across the world, the globe. It will have dramatic implications for genetic testing in some parts of the world where genetic testing isn't widely adopted at all, much less in frontline. So we're going to have to make decisions about patients' therapy very early now, especially if you're deciding between bevacizumab and not using bevacizumab and holding someone for a PARP inhibitor. And so there's going to be a lot of effort towards moving up genetic testing or wider adoption of tissue testing, tumor testing to look for those BRCA mutations. So that's the immediate implication. I think the next question is, does PARP inhibitor use in frontline therapy have benefit beyond a BRCA population? And fortunately, we have several trials that are maturing and will probably result out within the next year, we think. Paola-1 is bevacizumab plus olaparib versus bevacizumab in an all-comers population. This will be the first PARP trial, phase 3 PARP frontline trial that does not select by biomarkers. So that's going to be an incredibly important trial. If that's positive, then everyone's going to get a PARP and bevacizumab. Then the question will be, do the BRCA patients need bevacizumab or do they just need the PARP? I mean, it just adds to all these questions. PRIMA, which is the Tesaro study, is switch maintenance, niraparib following chemotherapy. Primary endpoint there is in a homologous recombination deficient population and then to an ITT. So if that's positive, that could be an expansion of who gets a PARP. And then VELIA is the veliparib with chemo with veliparib and veliparib maintenance or chemo without. Which also should result, we think, in the next year. So I think those three big phase 3 studies are done, and based on expectations, we think we'll hear results in 19. So things could really change based on those studies in terms of what the standard of care is for frontline therapy.
Pros and cons. Pros. It is uses the combination with a certain therapy drugs in the patient with a result ovarian cancer diagnosis with the cancer is the advanced or in pre-usually therapy patients who goes cancer come back. Cons. The cons of the drugs are mainly the adverse effects with the can be vertigo, anorexia, uh, hard to reach, chanted in the ability to the tasting food, diarrhea, within lost of its basic chances.
I think that certainly it's an exciting time in ovarian cancer because building off of the results of SOLO-1, where we saw the significant advantage to adding a PARP inhibitor for those with a germline or somatic mutation, we now see that there's potentially advantages from the data that we learned in Barcelona at ESMO in 2019, now published in the New England Journal of Medicine, and the study being PALO-1 that you just alluded to, where not only do patients with germline and somatic mutations benefit from PARP inhibition or the addition of PARP to their treatment, but you also see really the same type of thing for all comers. And I think that data is something that is very important for the audience to understand. So if you look at PALO-1, you know, in the BRCA group, we saw a hazard ratio of 0.31, which compares very favorably to what we saw in SOLO-1, which was exactly the same essentially, where it was 0.3. So that's very reassuring. What's interesting though is, and I think a lot of people forget about this, with PALO-1, you're not only comparing it to a control arm, but that control arm is an FDA-approved active drug in the case of bevacizumab. So this study did a 2-to-1 randomization to receiving either the olaparib plus bevacizumab or the bevacizumab plus placebo. So in that placebo arm or the control arm, you actually had bev, which we know very well is active. So very interesting in terms of looking at that. And then we have this whole concept of homologous recombination deficiency. So these are patients that don't have a germline or somatic mutation, but have other genes and other pathways where they have the phenotype as if they had a BRCA mutation. And so we expect them to behave similarly, maybe not quite as great in terms of magnitude of effect, but very similarly in terms of patterns of a response to a PARP inhibitor, and capitalizing upon the leverage of these DNA pathways that we can drug. And so indeed, if you look at the results from PALO-1, if you look at the HRD population that included those that had a BRCA mutation, we didn't see really much movement. So 0.31, right, for the BRCA mutated, it only went up to 0.33 if you took all the HRD patients. And what's interesting is if you pull out those BRCA patients, so now you don't have those in your group, and you're just looking at HRD alone. So these are patients who have exhibited homologous recombination deficiency, and we pull out those with BRCA mutation, either somatic or germline, you still see a significant effect.
Applied in Ecuador. Studies have been carried out the SUS has on the board, the San Francisco, the Quito University, where the treatment of CAR patients using bevacizumab is the evaluating and it was food is evaluating and it was food that they evaluating and they improved improved them in their health. The conclusion, bevacizumab is the drug used as part of the chemotherapy therapy for patients with ovarian cancer. Bevacizumab is a class of the medical angiogenesis inhibitor. Their use is to low or stop the growth of the tumors. There are than most, but that is the summer for other types of the shared mototherapy. Thank you.